case of cleft palate. A 2-year-old female child accompanied with the mother as the informant to the OPD with chief complaints of the defect in palate since the birth. The history of the presenting illness: the child presented with defect in the palate since birth. It is associated with feeding difficulty and regurgitation of feeds into the nasal cavity. There is history of frequent cold and cough. It is also associated with abnormal speech pattern. There is no history of ear discharge, and there is no history of any other associated congenital anomalies. The child is born to full-term pregnancy, delivered through normal vaginal delivery to non-consanguineous parents as the second child. The birth weight of the child is 2.8 kgs and has cried immediately after birth. There is no history of breathing difficulty, NICU admissions, cyanotic spells, or sleep disturbances. The child has achieved the milestones as per age and vaccinated as per schedule. Coming to the antenatal history, there is no history of fever, no history of radiation exposure, no history of intake of drugs for epilepsy, steroids, or retinoids. The folic acid intake is present as per the standard antenatal care. There is no history of smoking or alcohol intake. The family history: there are history of similar complaints of defect in the palate present in mother and the elder brother. Both were operated for the same. There is no history of any other congenital anomalies in the family members. General examination: the patient is examined with the parental consent in a well-lit room. The child is active and playful. There is no pallor or cyanosis. The vitals are normal. The height, weight, and the mid-arm circumference of the child is within the normal range. Facial symmetry is maintained. The systemic examination, which included the calvarium, cardiovascular respiratory systems, GUT, GIT, is also normal. Local examination: the lip and nose are normal. The palate examination: there is a cleft in the palate involving the uvula, soft palate, and the hard palate posterior to the incisive foramen. The cleft width is approximately 12 millimeters with palatal shelves oriented horizontally. The vomer is in the midline and free. The soft palate movement is present. The examination of the rest of oral cavity and the ear examination is normal. Diagnosis: my diagnosis is a group 2 cleft with positive family history and no syndromic association in a 2-year-old female child.
Okay. So this is a group 2 cleft. Can we go to the history? Can we start from the history, Dr. Ramya?
Yes, sir. Yes, sir.
Okay. This is a 2-year-old female child.
Yes.
And any other history of congenital anomalies? So how specifically do you ask for any other congenital anomalies that may be present?
We ask for any history of cyanotic spells in the child in the perinatal period, and if there are any history of sleep disturbances, any feeding difficulty, and hearing. Is there any hearing loss in the hearing difficulty in the child? To rule out the other congenital anomalies like
Vactal anomalies will rule out.
any limb anomalies are present to rule out the Vactal van der Wood syndrome or the velofaciocardial syndrome and the Pierre-Robin sequence.
Okay. In these congenital anomalies, so what are the common congenital anomalies that are associated with cleft that you know?
Pierre-Robin sequence is present, sir. There is also van der Wood syndrome, and trisomy 21 children are also associated with cleft palate. Vactal anomalies, there is an association with the cleft palate. Not present in all patients, but it is there, sir. Association is there.
So what is the specialty in van der Wood syndrome? What other clinical feature allows you to diagnose van der Wood syndrome?
Along with the cleft lip or the palate, there is also the lower lip pits or sinuses are present, which helps us in a diagnosis towards the van der Wood syndromes.
Yes, and other syndromes that you know with cleft lip and palate?
Treacher-Collins syndrome, Apert syndrome.
Stickler syndrome.
So how would you say Treacher-Collins syndrome? What are the other involvement that are present?
The child will also have hearing loss, and there is also craniosynostosis in the child.
Okay, and anything with the ears? Any ear deformities that can be present in Treacher-Collins? Microtia.
Yes, sir.
And there is another syndrome that you said, Apert syndrome.
Yes,
so what other features do you look for to call it as Apert's?
Craniosynostosis is present, sir. There is also maxillary hypoplasia in the child.
Okay.
It might be associated with hypodontia.
Okay. Anything on the hand? Anything on the hand that tells you that it's only upwards?
Syndactyly might be present.
So usually is the syndactyly simple or complex?
Complex syndactyly.
Yeah. So complex bilateral complex syndactyly is hallmark of upwards.
Apert syndrome.
Okay. Um, so what abnormal speech is usually complained by a child by the parents with cleft palate? What is the
Um,
abnormality in the speech?
the palatal speech is defective in the cleft palate children, sir. So the labials labials and the dentals like the letters P, B, D, and T are not spelled properly. For example, if the child has to pronounce daddy instead of daddy, the child might be pronouncing it as gaggy. Words like that, the child parents will be
So that is because of escape. So what do you call that escape?
nasal air emission is present. Hypernasality is also.
Hypernasality. Okay. Mm, we'll go to the next slide.
Yes, sir.
Child birth weight of 2.8 kgs. Okay. So therefore, it's a 2-year-old child. So all the vaccinations should be as per schedule.
Yes.
Um, child achieved milestones as per age. Okay. Next slide, please. Yeah. No history of fever. Any drugs that are in that you know in particular that are linked with clefts in antenatal
Phenytoin,
consumption?
phenytoin has a tenfold increased risk of developing cleft, sir, in the child.
Okay.
Then there are also ACE inhibitors and angiotensin receptor blockers drugs are also, there is an association with the cleft palate, sir.
Okay. And family history.
Yes,
So
sir.
who else is affected in the family?
The mother and the elder brother are affected, sir.
Okay. So in family history, usually, are there any entities that you know that these have more genetic history? Like you have two entities. One is cleft palate alone,
Yes,
and the
sir.
other entity is a cleft lip and palate entity. So is
Yes.
there any difference in the way there can be a family history between the two entities, or are they the same?
Um, Cleft lip and palate has more predisposition of familial
Isolated cleft palate has more predisposition
syndromic
towards syndromic.
syndromic association, but
Syndromic association more with isolated cleft palates.
Okay. Anything in between as compared to sex, which isolated cleft palate is more commonly seen in which individuals,
isolated
male or
cleft,
female?
isolated cleft palate is more commonly seen in females, sir.
Yes. Okay. And regarding the family history, so suppose this patient had come with you before the second child was born,
Yes, sir.
and there is a mother that is affected and a first child that is affected.
Yes.
So the parents suddenly ask you, what is the risk that the second child can have a cleft? So what would you tell them?
With the one parent and one sibling affected, the chance of the next child having it is having the only cleft palate is approximately 15%, sir.
Okay,
So we can give them an approximate risk that the next child might have cleft palate.
that is a significant risk,
Significant risk, yes.
15%. So that's why we can see the second child has got affected.
Yes, sir.
Next slide. General exam. Okay. Uh, So when you see the height, weight, and mid-arm circumference, so are there any criteria that you want to measure when taking in height, weight? Is suppose the patient comes for as a follow-up, do you want to ask anything and or do you want to plot the height, weight, or anything? So there is something called as growth charts.
Yes, sir.
Yes.
So can we use growth charts to measure the growth?
Yes, sir.
Yes.
Okay. So in the growth charts, what are the common growth charts that are used for children with cleft? So there can be a weight and age growth chart, and another growth chart is weight and
Right.
length.
Right.
So in the weight for age growth chart, what will you know?
Rajesh, sorry to
Madam,
interrupt you. A
swear, madam.
small submission, if this team don't answer anything, the team 2 you can ask, okay?
Okay,
So the
madam.
same will happen to them also.
Okay,
So
madam.
that is a competition. So you can ask if you feel these people not answering, you can ask the team 2.
Okay, madam. Yeah. Uh, Altaf sir, you want to add something? You are muted, sir. You need to unmute yourself.
So we have a similar set of questions. So you feel, I mean, do we need to do the other team as well, or we are done with this?
Uh,
The team B,
yeah, ma'am.
the
Madam Lakshmi, madam,
that
the team B also, we should do it once this team
Actually,
finishes. Or?
team 2, the other two panelists will ask questions.
okay,
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 If
I
they
madam.
don't
understood that.
answer anything in group 3, these team 1 can answer.
Oh, excellent, excellent. Yeah, I
Okay.
understood
There
that.
may be
Thanks.
little overlap because cleft is almost same. So
Very
Yes.
much, madam.
even then, no
Yeah,
problem.
very much. Yes, I understood that because you brought in the other team. I was a little bit confused, and both of us, me and Rajesh, were a little bit confused. Now I'm clear. So I have one question for you. So you said that this is a non-syndromic cleft palate, yeah?
Yes, sir.
So for you to say that, one more criteria is there, isn't it? Should you not look at the milestones?
Yes, sir.
So if you do not have the means of assessing, you need a clinical psychologist to see. I mean, 99.9% of the cases you don't need if the child is making eye contact and has the normal pediatric milestones, it should be all right. So you might have added milestones to this. I mean, your examination has been quite exhaustive, but you might have added this as well. That would have helped.
Yes.
And yeah, I think we can go. I mean, go ahead, Rajesh.
Yeah. Can we go to the next slide, Dr. Ramya?
Yes, sir.
Okay. This is a cleft in the uvula. Okay. Next one. This is the last. Okay.
Yes.
Can we go to the previous slide? Yeah. So, what is your diagnosis now?
Diagnosis is a group 2 cleft, sir, with no family history and no syndromic association, sir.
Okay. So, group 2 cleft, how many groups are there in this
According to the
classification?
Nagpur classification, 3 groups are there, sir.
Okay. Who proposed the Nagpur classification?
C. Balakrishnan, sir, has proposed the Nagpur classification, sir.
Okay. So, this is a group 2 cleft.
Yes.
Yeah. So, since you have made your diagnosis and the age of the child is more than 2 years, how would you like to manage this patient now?
Uh, as the child is 2 years, the ideal age of planning a surgery to a cleft palate is 12 months. So, as the age of the child is 2 years, first I would like to explain the outcome, the compromised outcome of the speech after surgery, and also genetic counseling will give to the parents of the patient. And and also the cleft is wide. We'll explain the post-operative complication and also need for future surgeries. If there is any velopharyngeal insufficiency, I'll explain to the patient attenders, and then I'll proceed with the blood investigations, and I'll plan for surgeries.
Okay. So, what is the ideal age for cleft palate repair?
It is about 6 months to 12 months, sir. 6 to 12 months, as speech starts at 6 months. Some say it is from 9 to 12 months.
Ideal age. So, if you were to say just one digit in
Yes,
age, so what would you tell?
9
about
years.
10 to 12 months, I will say.
So, why is that?
It depends on the compromising the maxillary growth if you do at an early age, there is a risk of compromising the growth of maxilla, that is maxillary intrusion may occur. And also, we have to balance between the maxillary growth and the speech development of the child.
So
So
usually it is for speech development, and speech development starts at
6 months of age.
Babbling.
Rajesh, if you
Madam.
are not satisfied with the answer, please involve
Okay.
the team 2 also.
Okay. Can we ask team 2 as to what is the ideal age for palate repair?
9 months, sir. 9 months, sir.
Okay. And team 1, so apart from age, is there any other criteria that you will look for surgery?
The weight of the child,
Yes. So what is the average weight of the child that is considered for palate repair?
approximately 10 kgs
10
of weight is considered to be optimal to take up for the surgery, sir.
Okay.
Greater than
Can I
10.
ask team 2 as well? What is the optimal weight?
10 kgs.
How much?
10 kgs.
Okay.
10
10
pounds, 10
kgs can
pounds.
be a little
10
too
pounds.
taxing.
10 pounds, sir.
10
It
kgs.
is 8 kilograms. So 8 kilograms is the norm. And okay, so this is a 2-year-old child. So therefore, the age milestone has been reached. The
Yes.
only milestone is per as the weight. So what did you tell the weight was, Dr. Ramya?
We were not given the information of the present weight, sir.
Okay. So, okay, we consider that the weight is adequate. So
Yes.
it is more than 8 kilograms and you
Yes.
want to proceed.
Yes.
So you want to do a TLC count. Anything specific that you have that you need? Why are you asking for a total leukocyte count, Dr. Ramya?
We want it to be less than 10,000 so that we know that there is no infection because we are going to operate in a clean contaminated field
Respiratory.
and no respiratory infections are there to rule out both of these things. It will help, sir.
Okay. Anything anything that total leukocyte count has in
Uh,
predicting any post-operative recovery outcomes? Do you know of any correlation between the two?
So,
Only 3 minutes left,
Okay.
so you want to confine to the
Yeah.
basics, or
So
you
we'll go
want to
ahead with
go
the
for
surgical management. So anyway, you have planned for the surgery.
yes, sir.
So can you tell me briefly what is what is the name of the gag that you'll use for this procedure?
Dingman's mouth gag, sir.
Okay. And so you have put a Dingman mouth gag.
Yes,
And
sir.
what is the surgery? What is the kind of palatoplasty that you would like to do?
As the cleft is wide, and I would like to go for von Langenbach's palatoplasty for the hard palate along with the intravelar veloplasty, sir.
Okay. What do you mean by von Langenbach type palatoplasty?
Von Langenbach type of palatoplasty is a bipedical mucoperiosteal flaps with the it has two incisions, one in the along the margins of the cleft and the lateral releasing incisions will give, sir.
Okay. The two pedicles, what is the main pedicle?
Greater palatine artery. It's a
What is the other pedicle?
It is a nasopalatine artery from the incisopheromanus.
So what is the position that you'll keep supine with neck hyper? Okay. What
Yes.
is the infiltration that is used for palate repair?
I'll give a 1 in 2 lakhs units of adrenaline. We'll give at the along the margins of the cleft and at the along the around the greater palatine vessels and uvulas.
Okay. So approximately how much amount of local anesthesia fluid will you inject in this child? Say the child is approximately say 12 kgs. So
Yes,
how much can you inject?
6 mg up to 6 mg we can give, sir.
6 mg of what?
Lignocaines.
Lignocaine. So the infiltration is mainly for 1 in 2 lakh saline, adrenaline saline.
Yes.
Yes, sir.
Saline. Yes.
So what is the any idea of the dose of adrenaline that is used?
We'll take 1 cc of 1 in 1000 adrenaline, sir. It is mixed in 200 ml of NS along with 5 cc of 2% xylocaine, sir.
Okay.
So
So
this
this
gives a
approximately
concentration.
comes to 1 ml per kg body weight of infiltration that can be given.
Yes, sir.
Okay. So what is the suture material that is used for pallet repair?
40 monocryl we use, sir. Round body 40 monocryl.
So round bodied. Okay.
Yes.
Do you want any other suture material, any other kind of needle that you know in 40 monocryl?
5x8 needle can be used, sir.
Okay. So can you tell me what are the steps of the surgery?
Yes, sir. In the first stage, we'll give the incision, sir. We give two types of incision. One at the along the margins of the cleft. We lie towards the oral mucosal side, sir. Along with that, we'll give the lateral incisions that extend from the maxillary tuberosity in the posterior aspect towards the anteriorly. We extend up to the cleft margin, sir. Just a 1 centimeter anterior to the cleft margin, and we'll elevate the flaps from anterior to posterior direction, sir.
So what is the muscle that is present in the soft palate that you think is important for production of normal speech?
Levator.
Levator villi palatini is important for speech.
Okay. What are the other muscles that are present in the soft palate?
Tensor villi palatini, musculus uvulae, palatoglossus, and palatopharyngeus.
Okay. What is the nerve supply of the levator palati?
Levator palati is supplied by
9th and 10th.
pharyngeal plexus from 9th and 10th.
9th and 10th cranial nerves.
So what is the abnormality of the insertion of the levator palati in a cleft palate?
It gets inserted into the cleft margins and to the posterior aspect of the hard palate, sir.
Okay. So what
Rajesh,
does
time
IVD?
is over for the discussion of this case.
Okay, madam. Altaf sir, anything that you would like to add?
I'm fine. You can also add whenever, see, my next set of things has some questions. Some of so we can get on there. Then if there is any questions, you can also add on to it. So shall I, anything else,
we'll
madam?
proceed with Altaf sir's
I'll
spotters.
screen share. Yes.
This
yes,
is for team 1 only. If they don't answer, the team 2 can answer.
Yes.
Okay. Shall I go to screen
minute.
share?
I'll share, sir. Slides are with me.
No, madam. I have a set of slides. It'd be better if I share because I
Okay,
also
sir,
have
okay.
sequences to it.
Okay.
Okay, I'm going ahead. Where is this?
Stop channel open share.
Multiple share kada, no problem.
Don't touch
Don't
a set
worry.
of screen. Okay, are you able to see?
Yes, sir.
Yes.
Are they happy kada?
Can I go ahead?
Yes.
Yes, sir. Yes, sir.
Okay, it's a similar picture, very similar to what Rajesh showed. So I have a set of questions with this. This is a baby who was diagnosed as having a cleft during the anomaly scan at about 18 weeks of gestation. So the patient's the mother calls you and says, I have a cleft baby. And when would you arrange for the first consultation?
I would arrange the first consultation immediately when immediately after the birth of the baby, we'll arrange the first consultation.
Does the other team have any questions? Any answers? Any other answer different from this?
So, sir, when
Team two?
immediately after diagnosis of the by ultrasound, we'll call the mother and we'll explain her the.
Yes, you need to have the first consultation beforehand because I told you the diagnosis was at 18 weeks.
Huh?
Very, if it is, we need to first make sure that this is not part of a syndrome. If it's not a part of a syndrome, there is no reason for anything other than going ahead with the pregnancy, though it's up to the parents to decide. If it is syndromic, then if it's not compatible with easy rehabilitation, there's an option for terminating the pregnancy. And the earliest, what is the latest time that the law allows you to terminate pregnancy? Team one, please.
20 to 22 weeks.
Yes. So you still have 4 weeks if you investigate the baby. Okay, that's number one. So the baby now is, so you have consulted with the patients, counseled them, given them the options to decide how to go ahead with it. And then they go ahead with the pregnancy. The baby is born. And as soon as the baby is born, they come to you or they call you. So what will you look for in the baby, which I think you answered in the first things mostly. And what immediate help will the baby need?
So I would like to check if the tongue is in the normal position, and along with is there any mandibular retrusion. The help will be
Okay,
needing in
excellent.
the feeding. We'll explain to the mother how the child should be fed, and we'll explain them about the Haberman bottle, and the cross-cut nipples will be given to the patient mother, so that they help in the feeding, and there is no regurgitation into the nasal cavity.
No. I mean, see, the baby comes to you. You said, what difficulty is the baby and the mother likely to face?
Because first, before the bottle, we want to get the milk
Baby,
out.
baby unable to sleep in the supine position.
There is going to be
Respiratory
some feeding
insufficiency.
difficulty, isn't it? Do you expect
Yes.
feeding difficulty or not?
Yes, sir.
Okay. And if there is a feeding difficulty, how do you overcome it? One, you need to, what position will you keep the baby, put the baby to the breast? You will not put the baby to the breast. Will you keep the baby? What position will, I mean, what else can you do if the baby is unable to suck on the breast?
The position
It'll
will
be difficulty
be,
latching on, isn't it, at
yes,
times?
yes. A 45 degrees upright position will be advised, sir. And if the for breastfeeding.
And what will you feed the baby at 45 degrees?
What is the
Something
Haberman
that is
bottle?
readily available and sterile.
No, I mean,
The breast milk, sir.
what expressed breast milk, is that what we're trying to say, isn't it? Okay. And do you think a baby with a cleft palate like that will be able to suck directly from the breast?
No, sir.
Any team two, do you have any different answer?
No, sir. Baby can't suck from the breast.
Well, they can. In many instances, they can. If they take a larger portion of the breast into their mouth, the upper surface, the cranial surface of the breast acts as an obturator. It can close at times the cleft, and the baby can successfully breastfeed. But may not happen in all cases. And but it's worth trying. Even if the baby, the parent is, the mother is not able to breastfeed, will you still put the baby to breast periodically or not?
Yes, sir.
Why? If you only express breast milk, it's going to dry up.
Yes, sir.
You need constant stimulation from the baby for the breast milk to continue. And you'll also need supplements. We'll not go into that. So what I mean, you're done most of the investigations. What key investigations will you ask as soon as the baby is born? If it's not done routinely already.
Sir, 2D echo.
Both the teams can answer this.
2D echo, sir. To rule out the congenital anomalies.
Well, will you do an echo in every baby with a cleft palate? I mean, do you have pediatrician colleagues who can just assess the baby? If needed, then you do an echo. What else is always associated with cleft palate? You already answered partially with Rajesh earlier.
Ear
upper respiratory
abnormalities will be there.
Will you not do a hearing screen?
Yes, sir. BERA can be done.
Not BERA. BERA is something else.
Oh, sir.
What is routine hearing screen? Okay, doesn't matter. So you'll do a hearing screen, and if BERA is a test of conductive deafness, I mean, neurological deafness. So what you're looking for is what kind of, difficulty are you looking for?
Conductive
What's the
hearing
problem
was
with the cleft?
because of the abnormal closing of the eustachian tube. There is
Eustachian dysfunction. So the problem is in the middle ear or the inner ear with that?
middle ear, sir. In the
Middle
middle
ear. Okay, excellent, excellent. So we already spoke about scheduling surgery, so we will skip that question. What technique, surgical technique, will you adopt for oral lining, nasal lining, and nasal spray? What will you do with the oral lining?
Oh,
Oral lining, we'll try to close with the lateral incision as much as possible, sir.
Excellent. Yeah.
But if that
you,
is
you can do with the midline or you can add a lateral incision.
Lateral
Lateral incision is called, you already mentioned that, isn't it? What's it called?
S-shaped
Von
Von Langenbeck.
Yeah. So why would you not do a long flap in this? Easier, isn't it?
But the newer techniques like the Fowler's technique and the Von Langenbeck's technique, there is scarring is there in the postoperative period and the raw areas are present. The raw areas can bleed and
No, why do you mean my question? Let me rephrase my question. Why would you want to limit the incisions?
Because to reduce the scarring in the anterior premaxillary.
And what happens if there is extensive scarring?
That leads to growth of the maxillary growth, sir.
Okay, there could be rarely happens with Langenbeck. Very unlikely to happen if you place it correctly. But with a long flap, and particularly if it is associated with the lip, very high chance of mid-face retrusion. Okay, so that is for dealing with it. So you'll raise the flaps based on the greater palatine vessel. You already said that. So what do you do with the nasal lining?
Nasal lining,
what do you do in the...
Yes, sir. Initial incision along the margins of the cleft, I'll give the incision more towards the oral lining so that I can close the nasal lining
with a triangular flap
without any tension.
And if we are not able to close it, then we'll go for a Vomerin flap in the anterior.
Why would you not do a Vomerin flap to begin with? I mean, why would you not repair it? That's how the... where is the septum in a normal person attached? The lower border of the septum is attached to the palate, or is it in the air normally?
Palate, normal.
So will you not reconstruct that?
Yes, sir.
Okay. So you will repair anteriorly where there is the nasal septum. You will repair the nasal lining to the
heart, to
the
nasal layer.
Nasal layer of the palate. Okay, excellent. And posteriorly, where there is soft palate. So how will you move the nasal lining medially?
I'll give the dissection up to the end space on towards the lateral aspects.
And how will you medialize the nasal lining? Can you medialize the nasal lining? Because it's going to be, it's a wide cleft, isn't it? There's a width to the cleft.
Yes.
You will need to medialize the nasal lining. There are many techniques to it. We'll come to it. Since both of you, is the other team having any suggestions?
Sir, we like to go it in a stepwise manner, sir. First, we will try to close the nasal mucosa. If it is not approximating, then we'll release the muscles from the back of the hard palate for closure. Still, if it is not approximating, then we'll release the tensor palatini from the hook of annulus, or we'll divide it. Still, if it is not coming, then space of Ernst can also be released and the closure can be. If still it is not coming, then we can go for flaps such as buccal myomycosal.
I think you'll need to release all this. You need to release the nasal lining from the lateral nasal wall anteriorly, and you may want to release it from the... you may want to cut the tensor tendon just medial to the hamulus. So I'll show you. And let's.
Sir, Altaf sir, please excuse me
Yeah,
for
I'm just going
interrupting.
forward. Yeah.
Sir,
Yeah, I'm just going
no.
forward.
You briefly ask about the spotters like questions, and
Yes.
we'll give time to you to explain all these things at the end, sir. The discussion part you show and ask them to diagnosis are relevant points only. Again, you
Okay.
can describe the in detail at a later time, sir. We will give separate panelist time for you.
But the okay, the thing is, I'll just show you the slide. It goes like this. So I'll
Yeah.
quickly go. I'll go to the
No,
next
sir.
set of
Remaining
questions.
spotters are there for you. So you
So,
please
yeah,
ask
I'm just
those
going
things, sir, briefly. And
yeah, very quickly I'll finish.
yes,
Yes,
sir,
madam.
sir.
Yeah.
This
So I'll
don't.
just go the way it is. Yeah, I will not use that time later. So since I'm here, I might as well finish it. So you'll need to mobilize the oral lining, like you already said, nasal lining. Again, you need to repair the septum anteriorly to the nasal lining of the palate, and posteriorly you need to approximate the muscles. And many people would do an intravalvuloplasty. I don't believe in it. I used to do. I was trained by Brian Summerlad, but we won't talk about it. For you, intravalvuloplasty is a controversial thing. Sometimes it's done, and some people like it, some people do not. So this is the baby. Palate repair was done at 11 months. And we made very short Landenbeck release incisions and closed it with setplasties. This is the child at 4.5 years of age, and this is her speech.
Sir, okay.
Okay, this is the earliest we can do nasodendoscopy. So this is the next question. This child is.
Sir, let the other team finish their case presentation and discussion. So
Okay,
these you can ask to the both teams, and you can explain at the end
Okay,
of the
madam.
second team presentation, sir. Because most of the operatives are common.
Okay.
When you explain,
Then I
there
will
will be
skip
problem.
that.
Yeah.
I will skip that. I will only ask this question.
Sir,
What are the principles? Yes, madam.
we'll finish the group 3 presentation also. Then we'll project the spotters, sir.
So shall I go ahead with the spotter or not?
We'll withhold now. After
Okay.
completing the team 2 presentation, again you can
Yes.
start the spotters, and it will be
Okay.
open for the both teams, sir.
Okay, excellent, madam.
Yes.
We'll do that.
Okay, sir.
Okay, madam.
Thank you, sir. Thank you. Again,
you.
you can share the your PPT and we'll proceed, sir.
Yes, madam. We'll do that. Thank you.
Thank you, sir. Thank you very much.
1 minute.
Rajesh, you would like to share your post-op? Anything you would like to?
I don't have it right now, madam.
Okay.
But,
no problem.
Yes.
Then we
can go on to the next case, madam.
Sir? What, Rajesh?
We can go on to the next case, madam.
Okay. So I invite the moderators of the session. Kindly give your remarks, or you would like to share something, Dr. Bhattacharya, sir?
This is to team 1. Why do you give the infiltration, lignocaine infiltration? What is the purpose?
Sorry, sir.
What is the purpose of lignocaine infiltration?
Hemostatic effect, and also the hydrodissection. It helps in the hydrodissection also.
Hydrodissection to elevate which flap? What type of flap it is?
Mucoperiosteal flaps, sir.
Mucoperiosteal. Okay. How do you modify your medial incision along the margin of the cleft, how do you modify it according to the width of the cleft?
If it is a
Is
white
it-
left, I would like to.
Yeah.
If it is a white left, I would like to extend the incision just a bit more anterior to include the bit of oral mucosa to close the nasal layer in the anterior aspect of the cleft.
Right. Right. How do you skeletonize the greater palatine artery?
After lifting the mucoperiosteal layer on the lateral aspect, I would like to give you the periosteal incision on the lateral aspect of the greater palatine vessels and an instrument behind the vessels to
Which
dissect the
instrument?
rectangular rectangle
See,
artery.
it is adhered to the bone. You know, the vessel is adhered to the foramen, greater palatine foramen. And the purpose is to skeletonize it, to
Yes.
lift it up. So, how do you lift it up? How do you skeletonize it? Team 2? Yes.
Mucoperiosteal incision and separate the vessels with right angle.
Do you need to skeletonize it or not, first of all?
Yes,
Yes,
sir.
sir. We need to skeletonize.
Yes. So, it's a very important maneuver. How do you do it? If you are not careful, you will avulse the vessel.
Yes.
So, how do you do it?
Sir, we
We'll
can
give the-
use a Mitchell trimmer so that we can release the fine fibers which are attached to the greater palatine pedicle.
No, that's not the answer. The
Sir,
exact technical
we
way.
can foramen side on the middle, we can do the small osteotomy which releases the greater palatine artery.
No, you need not do osteotomy, posterior aspect every time. You can easily skeletonize it by a maneuver.
Sir, ask team 2 also.
we'll
I'm
use
asking
a
team 2.
right angle forceps to just dissect the-
Right angle forceps. No, that's dangerous. Okay. Do you
Sir.
free the muscles from the posterior border of the hard palate?
Yes,
Yes,
sir.
sir. We'll free them.
Why?
We want the muscles of the soft palate to lie in the posterior aspect of it, so that the sling is formed there, and so we release the.
But why do you want to release it?
To medialize the
Medialize the muscles.
नीरज है नहीं नहीं इंद्रमणि तो आ गया ना ये लोग तो चले जाएंगे अभी थोड़ी देर में
Do you break the hook of hamulus?
तैयार हो जाऊंगा तो
It's not practiced now, sir. Earlier it used to be done, breaking of the hook.
So
of
if you practice it, what happens? Why it is not practiced?
इंटरवेंशन नहीं है
Sir, because it is causing deformity at the eustachian tube, hearing deformity.
No. Okay, I'll answer it later.
Sir, A.K. Chaudhary, sir, time is.
Thank you very much. I'll take only 2 minutes.
Sir.
Yeah. Well, as far as the clinical presentation is concerned, and the presentation was good,
Yes, sir.
and the clarity was also good, but the conception has to be improved, and the confidence you are having has to be also improved. So, as far the presentation you have told in the symptoms and your local examination, you should have talked about what is the physical difficulties, what is the feeding difficulty of the patient. Was there a nasal regurgitation, swallowing difficulties, and what position the patient has to taking, and what type of feeding is being given by the bottles, and the bottle, what type of bottle, all that is very important as for the nutrition and as the patient history is concerned. And I ask a question, what is the goal of your surgery? You have shown about the surgery. What is your goal?
The goal of surgery is a normal speech and a normal anatomy of the palate. Normal.
How do you get it? How do you get it? By doing what surgical procedure?
For Wangenbach palatoplasty along with intravelar veloplasty, I'll do for the soft palate to get a normal speech.
So for that, what you get effect by doing that surgery?
The velopharyngeal sphincter closure.
Yes, very good. Then
This is achieved when the soft palate sling, levator sling is maintained. So we want to maintain that sling in the posterior aspect of the soft palate. And we also do not want to compromise the maxillofacial growth in the later stages. So we try not to scar the premaxillary region.
Okay, then what about the cavities, nasal and oral cavities?
The closure of the soft palate is done in 3 layers, and
to do it, how it is going to have a, what type of cavity it will be after doing a palatal repair? Water type anyway. And what effect is there with your veloplasty and also good palatal repair regarding the escutcheon tube? How does it affect and functionally what it affects?
in the palate, in the cleft patients, the eustachian tube function is hindered because of the abnormal insertions of the palatal muscles. After the repair, we expect
by doing surgery, what you are going to give the function of the eustachian tube and the function of the patient as far ear is concerned. Second, team second. Can you answer this?
After the surgery, there will be proper function due to the opening of the eustachian orifice. There will be equilibrium of the air maintained between the middle ear and the oral cavity.
Yes.
It reduces the exudative failure and all the problems.
Yes.
Fluid will be drained out from the middle ear.
Yes.
And all can be reduced. If still persistent, this thing is that then we can introduce a grommet in the eardrum and improve the hearing of the child.
Yes, absolutely correct. Absolutely correct. Anyway, madam, thank you. We are lacking time, so I don't think want to take more.
Thank you, sir. I'll invite the judges and other senior faculty if they want to ask any questions or contribute.
Do you consider primary pharyngoplasty? Team 1.
No, sir. After surgery, I will assess the speech at 4 to 5 years of age. And later, if there is any velopharyngeal incompetence, we'll go for a pharyngoplasty.
Suppose there is a fistula of 1 centimeter diameter at the junction of hard and soft palate. What will you do?
As the fistula is wide, I will go with the redo procedure, sir. I will again
redo.
Yes.
Team 2.
Sir, if there is any fistula also, we will do a speech evaluation, and if patient has any symptoms regarding URI, speech difficulty, anything, then only we'll go for a surgery.
I'll block the fistula.
I told you it is 1 centimeter diameter.
Yes.
Okay. So if there is a speech abnormality, then only we will handle, otherwise not.
No, sir. I will assess the speech after blocking the fistula.
There will be speech defect. Okay. There is a fistula, there will be speech defect.
Yes, sir.
And not only speech, the food particles will also come out through the nose. So you have to repair.
Sir, then we will keep a obturator near the fistula, and we'll check if there is any
obturator lifelong?
No, sir. Temporarily we'll put the obturator. We'll check if the abnormality.
The child is growing. How frequently you are going to give the obturator? How the child is going to adapt it? I'm asking you surgical repair.
The surgical repair, if the fistula is very wide, we can go for
1 centimeter diameter.
Yes, sir, it's wider. We'd like to go with MM flaps, sir, for the repair, sir, next time.
What is the principle of fistula repair?
Sir, if the patient child is having symptomatic nasal regurgitation, we have to surgically.
Forget about all that. What is the principle of fistula repair?
We have to close the fistula in 2 layers.
2 layers. So how will you get the 2 layers? Correct.
Yes, sir.
Sir, whenever there is a fistula, there will be a mucosal defect, and also the muscular also will be deficient, sir. So we have to completely open it, do again layer-wise closure of the muscle and also the mucosal layer.
No.
If
nasal layer will close with we'll take the mucosa from the oral side. And
you have to have 2 flaps, one for nasal layer, one for the palatal. Okay.
Nasal.
So how it is designed, I'm not going to tell you in detail because time is short.
Yes.
And
attention to sir about the fistula. Can you tell me the fistula classification?
Sir. There is a separate session for palate fistula. So you are giving answers for them.
Okay, ma'am. Thank you.
Okay.
Thank
Thank
Right.
you, sir. Thank you very much. Now we'll go ahead with the. There are no judges to ask any questions or any other faculty.
What is your idea? What is your idea about the spotter which Dr. Altaf Hussain showed that in it was diagnosed before the birth? Okay. So, what is your idea about the in vivo repair of cleft lip? Cleft lip, I'm asking, not cleft palate. Any idea?
Uh,
Number 2.
Yes, sir. Nowadays they are doing intrauterine closure of the cleft lip, sir. But cleft palate still not yet came, sir.
Why
But
it is not very popular?
Scarless procedure, sir.
That is advantage. I'm asking why it is not popular.
Because mouth opening will be difficult in neutro.
No. Team 1? Okay, thank you.
I invite the next team. Very good.
Yes, ma'am.
Next. I invite the team 2 and team of PGs from JIPMA and the panelists Dr. Parvati and Dr. Anjana Malhotra to start the discussion.
Share PPT. ma'am.
I think you can start
1
your
minute.
presentation.
Yeah. 1 minute.
Good evening, all. Today we are going to present a case on GP3 cleft. The community history is a 9-month-old female child brought by mother with complaint of discontinuity of the upper lip and palate on the
Share
left side.
your PPT, please.
Shared, ma'am.
Shared.
Yes, ma'am.
Yes.
Yeah. Okay.
Yes, we can see.
There is history of difficulty in the feeding with nasal regurgitation. There is also a complaint of recurrent upper respiratory tract infections with no other deformity in the body. Coming to antenatal history, natal and postnatal history. She is a born full-term, normal vaginal delivery. Her parents aged 29 and 26 years of age, born out of a non-consanguineous marriage. Folic acid tablets were taken by the mother in the antenatal period. There is no history of any fever with rashes, radiation exposure, or drug intake. No history of any maternal diabetes or epilepsy. The mother is a non-smoker and a non-alcoholic. Child cried immediately after the birth.
Just stop. What are the maternal influences which are thought to cause clefting?
Ma'am, diabetes mellitus is an independent risk factor, and also alcohol, smoking, and rubella infection, drug intakes such as phenytoin, and some hydantoin, and some teratogens such as thalidomide. All these are the influential factors.
What about cooking on smoke chulhas? Is there any correlation with the smoke in the in utero problems? Have you read any studies?
No, ma'am, not sure, ma'am.
That is supposed to be one of the other factors. And what about the folic acid levels? All antenatal mothers are now given folic acid. Now, do you think it is able to achieve the levels which are needed if you start it in the antenatal period?
There is no sufficient study to accept or encourage this, like folic acid reduces the incidence of cleft.
No, it is linked clearly to low folic acid levels in the mother's blood at the time of conception. But with the government giving iron folic acid to all mothers when they intend antenatal, is that folic acid enough to prevent clefting? That is my question.
Yes, ma'am, enough.
It is not enough because by the time the mother realizes she's pregnant, by what time does the lip and palate develop? At what period of gestation?
Starts at 6 weeks and complete by 8 weeks.
Yes, so by the time the mother realizes she's pregnant, by 52 or 56 days, the development is almost complete, isn't it? So that is why the program is now being shifted to giving folic acid to teenage girls. so that they have enough folic acid levels at the time of pregnancy. Okay. Continue.
To family history, patient is the only child and no similar congenital deformity was found in the family. General examination, child is examined in the presence of mother in a well-lit room after making the child comfortable. Child is calm and active. There is no pallor, icterus, clubbing, cyanosis, lymphadenopathy, and edema. Vital signs are normal. And on head-to-toe examination, there is no facial asymmetry, no lower lip pits, no abnormal.
Where is lower lip pit seen? What is the syndrome known as?
Van
der Waals syndrome.
View
Yeah,
order.
what do those pits represent? Till where do they extend? Have you ever seen it being operated?
No, ma'am. No, ma'am.
Okay, so it extends in the lip only. It goes right, maybe going to about 1 centimeter. Depends, and it's a lip sinus. Okay.
Yes,
Continue.
Systemic examination appears to be within normal limits. To local examination, there is coming to lip, there is a discontinuity of the lip and white roll on the left
I
side.
think we are not discussing the lip today. Is it correct, Dr. Lakshmi? So we move on to the palate.
No, palate only, but a few things, when to do, what to do, all those things you can ask. Not the lip repair already completely covered in the session 1. But if you want to ask what is the difference between the group 3 and only group 1 cleft lip repair, you can ask.
Okay. So you can continue the description. You can give the lip description also.
Yeah, not the methods, but differences you can ask.
Going to lip, there is a discontinuity of lip and white roll on the left side with visible alveolus. The peak of Cupid's bow is raised on the cleft side. Lip height is reduced on the cleft side. The vermilion tubercle is deficient. Bunching up of the muscles is seen on the lateral element. Lower lip is normal. Alveolus, there is a discontinuity of the alveolus. Arches are malaligned. The non-cleft is anterior to the cleft side. Medial element has 2 anterior incisors.
Incisors, do you
continue?
see here? You be specific about the incisors.
To palate, complete cleft with involvement of the hard palate, soft palate, and uvula is seen. Width of the cleft is compared with width of the palatine shelves is more. Status of the uvula is bifid, and palatal arch is discontinued. The remnant part appears to be flat. The vomer is in midline with both sides are visible, and tonsils appears to be not enlarged. And posterior pharyngeal wall there is
Why
no
is it important to see? Why is it important to see the vomer in the examination? Why have you mentioned it?
Ma'am, when we are when there is any deficient enclosure in the nasal mucosa, we need to raise the vomer flaps. So for that, we need to examine the vomer.
So although the lip is unilateral, you are saying that you could see the vomer in the midline on both sides.
Yes, ma'am.
It's not attached to any side?
No, ma'am. As part of visible, it is not attached.
Okay, so often you can get these combinations where the lip is unilateral, but the palate is of a what type of palate is this?
Bilateral. Bilateral complete.
Oh, that is the type. That is the classification. But for operative purposes, if the vomer is in the midline, what type of palate do you see the vomer in the midline? Team 1? Team 1, do you have any clue? Team 1?
No, ma'am.
Vomer. The vomer is in the midline here. It's not attached to either side.
Yes, ma'am.
So where do you see the vomer in the midline? In which type of a cleft?
In the complete bilateral cleft.
Yes, correct. So usually in a complete bilateral, the vomer is not attached to any side.
Yes.
Continue.
Tonsils are not enlarged, and posterior pharyngeal wall, there is no redness seen. To nose, there is a discontinuity of the nasal seal and floor on the left side. Nasal floor is wider on the left side. Columella is shorter on the cleft side. The columella base is shifted to the non-cleft side. Nasal tip is broad and deviated to the cleft side. Nasal septum is deviated to the non-cleft side. Ala is flat on the left side, and the alar facial groove is obtuse. The alar base is shifted down and out, and there is angle between the medial and lateral corolla is obtuse. To diagnosis, the left side complete cleft lip, alveolus, and palate with nasal deformity without any syndromic association in a child aged 9 months. And according to NAPU classification, it is GP3 left CL, cleft lip and palate.
So apart from the Nagpur classification, are there any other classifications you know?
Ma'am, VU classification.
Yeah, the WO classification and
Carnahan's classification.
Kanan's tribe twice.
That's right.
So could you tell a bit about the Kanahan's classification?
Is based on the embryological, it has divided, and the apex of the Y will be the incisive foramen, and right side it will be 1, 2, 3. Then left side will be 4, 5, 6, and towards the midline in the hard palate, towards the midline in the soft palate, it will be the rest of that.
Correct. Now, in this baby has come to you at 9 months. What is the weight? Have you seen the weight?
No, ma'am, not. We didn't get the information about weight.
Okay, so the weight is adequate. The weight is more than 8 kgs. What repair you will do first?
Ma'am, we'll go with palatoplasty, ma'am.
Why?
Because from 6 months to 9 months, the palatability of the child starts, and we have to complete our palate surgery before 1 year of age. So as the speech is going to start, so I will go with.
Not 6 months. I mean, yeah, after say by 8 to 9 months, as everybody was saying, when the babbling speech starts, you have to do it and complete it before the definitive speech begins. So you would like to do the palate before. Team 1, do you have any other answer?
No, ma'am. Same. We'll do the palate repair first.
Or we can go with the.
Okay, so I agree.
Yes.
So why will you do the palate repair first? One is okay. The age is correct for a palate repair, but suppose you do the lip and call him back in 1.5 months, in 6 weeks. Then what is the problem?
The problem is that the parent might not bring the child back because the facial deformity is not so evident if the lip is corrected, and
Yes, correct. So that is why, yeah, that is why when the child has come to you at this age for the first time, it's better to do the cleft palate in our setting. Okay, continue.
I would like to proceed with first.
Is Dr. Parvati there? Parvati, would you like to ask something?
Yeah, are we audible? There is a. I was not able to
Yeah,
communicate.
Yeah, you're audible.
Audible.
Okay. Can you go back to the slides? The palette slide. So, how do you differentiate between the unilateral and bilateral clefts? Looking at the palette picture.
We can see the warmer in case of bilateral palates. In
In unilateral clefts, you don't see the vomer.
It will be attached to one side of the
Which side?
Non-cleft side.
Non-cleft.
Okay, that is the differentiating point between the unilateral clefts and bilateral clefts.
Yes.
Okay. So, you have reached the diagnosis. Can you tell me about the embryogenesis? How does the cleft lip and palate occur in unilateral cleft? What age? How the embryogenesis happens during the development of palate and lip?
At 4 weeks of age, the facial morphogenesis will start. The frontonasal process will divide into medial and lateral nasal processes, and maxillary prominences are there on either side. The maxillary prominence will attach to the medial nasal process, which will give rise to the lip and the anterior palate. The palatal shelf, which are arising from the maxillary prominence from either side, will form the secondary palate.
Okay, where do they join? Primary palate and secondary palate?
That incisive foramen. Incisive foramen.
What happens to the lateral placodes of the frontonasal prominence?
Frontonasal prominence will attach to both the maxillary prominences, ma'am. Palatal
No,
shelf.
the lateral placodes of frontonasal prominence. What happens to them?
Form the ala of the nose.
Okay. So the child came at age of 9 months.
Yes, ma'am.
So you are planning about the surgery. If the child comes earlier, what is your plan?
If the child comes before 6 months, we'll go for a lip repair, ma'am. Then we'll go for palate repair.
If the child, the parents comes at the antenatal phase, what is your approach?
When the parents come in the antenatal period, first we'll give them a counseling regarding the disease, the spectrum of the disease, and we'll explain them that this is a normal which can be cured by surgery. Then we'll explain them regarding the sequence of the surgeries to be done. Then we'll give them some assurance. Then we'll tell them mother to come immediately after the birth. Once the child comes after the birth, we'll again examine the patient, the cleft deformity. We'll check the weight, hemoglobin. Once we'll tell them, keep them on monthly follow-up basis, and each month, whenever they come, we'll check the weight. And we'll also advise the mother to go for a NAM. Since there's a wide cleft, the NAM can be applied immediately. And once NAM is applied, we'll tell them to be on monthly follow-up and we'll further tightening. And once the child has crosses 3 months, then we'll do a pre-op investigations, investigations, plan for a cleft lip repair. Once after 6 months or 9 months, we'll go before 1 year, we'll plan for a palate repair. Then once palate repair is all completed,
Okay,
then
we'll stop there. Okay, so the child came in the antenatal period and you have counseled, and the child has come in the immediate after delivery they came. And do you suggest TAM in all the cleft children?
ma'am, wherever there is a wide cleft, ma'am, in such cases, we'll or in there
Is
where
it a
there is
routine practice?
alveolus deformity is also more.
What is wide cleft?
Ma'am, we can do the palatal index by measuring the width of the cleft, measuring
Is it
of the
when you are deciding about the NAM, what are the measurements you are considering? Is it the palate? Is it something else? What do you consider it as a wide cleft?
Left of the lip and alveolus, we will evaluate,
Yeah.
ma'am.
What
And
exactly is done in nasoalveolar molding?
we will take measurements of the palate and the lip region, and will fabricate a silicone conformer, and that will be attached at the inside the palate and the nasal region as a nasal conformer also.
There are different ways of doing it. What age do you do it? When do you start doing it?
by 1 month, ma'am.
Even before
We
that?
should ideally start before 3 months. We should ideally start, and after 3 months, there is no use of this NAM.
You by 3 months you should be able to complete it. Immediately after
Yeah,
birth, you
pretty should.
what team 1 can answer that. Do you know at what age it can be started?
It is started at around 2 weeks of the age, ma'am.
Yeah. So there are different ways of doing the NAM. Do you have any idea what kinds of NAM techniques are available? Okay.
Modified Graham's device, Liam's Lewis device.
Can you be louder? I can't hear you.
Lewis device, modified Graham's technique is there. Then
Grayson's device we use.
Grayson's and
Lewis technique.
Lewis. Okay. So what is the mechanism there? Is it a passive or is it active?
The passive.
Passive, ma'am. Passive, ma'am.
It's an active
What is active?
We are
First, you will decide the answer. One is saying passive, one is saying active.
it's active. It's active from our side.
Team 2 can answer. It goes first to the team 2.
Passive.
Which is active, which is passive?
Nasal obstruction,
No, I am asking which technique is active, which technique is passive.
Graham's is passive.
It is not Graham's, it is Grayson's.
Grayson's.
Ah,
Only 5 minutes left for
okay.
discussion for
Okay,
panelists.
okay. Is it routinely practiced for unilateral clefts? Where is it used
Yes,
more
ma'am.
commonly?
Bilateral clefts.
Okay. So we'll go with the discussion about the surgery.
Yeah, so now you're doing the palate surgery for this baby. So they've already discussed which incision will you prefer?
So what is your surgical approach for this child? You are operating for the palate. So what is your technique you are going to follow?
Bardash two flap palatoplasty, ma'am.
Okay.
Okay. What will you use for the anterior part for the hard palate? Will you be able to get it together, the nasal layer?
Omarine flaps will be raised, ma'am.
Can you describe the
Yes.
technique? How do you close the palate here? Starting from the positioning, anesthesia and everything?
Yes, ma'am. After intubation by RAE tube, we'll keep the neck
What does
extended.
RAE stand for? Yeah, what does RAE stand for?
Ring Adair Elvin tube, ma'am.
Okay. What other
Okay.
tubes do you
What?
know?
Flexo metallic we can use, ma'am.
South pole. Okay.
Once after intubation, we'll keep the child in supine position and the neck should be in hyperextended and a ring should be kept over the occiput region of the head. Then we'll place
Under the occipital region. Okay.
under the occipital region. Then we'll place a mouth gag. Then we'll start infiltration. We'll keep a throat pack.
After putting the mouth gap, what is that thing which you want to check?
We have to check whether there is a obstruction to the ET tube, ma'am.
Yeah. What kind of obstruction? How will you know?
Respiratory pressure will be increasing in the mouth room.
And what can you see?
Fogging will be seen in the tube, ma'am.
Oh, that will not be seen properly. Okay. Then
Then we'll keep a throat pack, ma'am.
okay.
Then we'll start infiltration of tumescent infiltration all along the
Tumescent.
tumescent infiltration.
What is tumescent here in palate? What is
Tumescent
In
tumescent?
palate is the word tumescent used.
Where do you use tumescent?
2 minutes only there.
In our institution, we used to infiltrate with tumescent.
What is the composition of tumescent for this palate?
1:1000 of 1:1000 adrenaline mixed with 5 cc of 2% diglocaine in 200 ml of NS.
It is not called tumescent. It is regular adrenaline saline infiltration with lignocaine. Okay. Tell me about the technique.
Can you add bupivacaine instead of lignocaine?
Yes, ma'am. Can be added.
Anjana, please, operative session, you can start.
Okay.
2 minutes time is there.
Okay. How do you proceed with the surgery?
Then we'll start incision on the cleft margin of the cleft. We'll start giving incision and we'll separate.
You'll go from forward behind or behind forwards?
Forward to behind.
Team 2?
We would like to go with the incision posterior to anterior.
Why?
It is a convenient method, ma'am. Whenever we are doing, since we are standing on the head end approach, so we can move our blade easily from the posterior to the anterior.
What happens if you give anterior incision?
And blood ticking also won't obstruct our field.
Okay.
Yes, that's the answer.
Then?
Once we create a cleft incision, then we'll give an incision on the alveolar palato-alveolar junction, and thus we'll extend up to the anterior side to the up to the maxillary tuberosity. Then we'll start raising the mucoperiosteal flap till we see the greater palatine vessel. Once we see the greater palatine artery, then we'll skeletonize surrounding and stretching of the
But how do
periosteum.
you skeletonize? How do you skeletonize the greater palatine vessels? Professor Bhattacharya was asking this question.
We'll small attachments will be there for the greater palatine arteries, which we'll be removing by moving the hook or instrument surrounding the greater palatine artery.
Is it that? Anyhow, continue.
Once we really skeletonize and move, there is a movement in the greater palatine artery. Then we'll separate the muscles from the posterior part of the hard palate. Once we release this hard palate muscles, then we'll once all the layers have been created, then we'll start closure of the from the anterior part of the created palatal layer. We'll first close the nasal mucosa. Then we'll create a sling with the muscles forming levator sling.
You didn't tell that you will incise the vomer and put down the vomer flaps, no? How will you close anteriorly in such a wide gap without
Yes,
How does
taking
the
the vomer
nasal
flap?
layer close in wide clefts, unilateral clefts? How do you
we'll
close
try
the nasal layer?
We'll try a vomer flap. If vomer flap is not available, then we can go for buccal myomucosal flaps, which can be used
What
for
kind of
closure.
vomer flap you use?
Superiorly based membrane flaps.
Yes. Okay. Why did you choose two flap palatoplasty in this case?
One gum backs cannot be. It is there to, since the wide cleft is wide and it is a complete von Lingam-Blacks won't be to close the anterior part of the cleft. And BWK's procedure also, we can't close anterior part of the palate. So I will be going with Bardak's palatoplasty.
Is the all the unilateral clefts are operated only by Bardak's and von Langenbach's, or any other methods can be done? What is the criteria? How do you decide which technique to be used?
Based on the hard palate involvement, some techniques are there. Based on the soft palate involvement, some techniques are there. So if the hard palate is involved, the procedures are von Langenbach, BWK, and Bardak's palatoplasty. And also raw area extension palatoplasty, palatal extensionoplasty.
Alveolar extension palatoplasty.
Looking at the picture, can you say it is wide cleft, or you can do furloughs?
Oh, it's a wider cleft.
Wider cleft. That is the reason you won't go for furloughs. If it is a narrower cleft, can it be done in unilateral cleft?
Furloughs is mainly for the soft palate extension.
But still, the hard palate also you can use. The soft palate part is closed with furloughs technique, but the hard palate also can be closed.
Okay.
So when do you call it as a wide palatal cleft?
Once we calculate the palatal index, and the palatal index is divided into mild, moderate, and severe. If it is less than 0.2, it is mild. If it is 0.2 to 0.4, it is moderate. If it is more than 0.4, it is severe, madam. In case of moderate and severe, we'll call
How
it
is
as
it calculated?
Palatal, it's the amount of width of the cleft calculated by the width of the both palatal shelves on the opposite side.
Where is it calculated?
Exactly at the molar. Junction of the soft palate and hard palate.
Yes.
The whitest part.
Panelist time is over, Dr. Parvati.
Yeah.
So
One
conclude
more minute.
and show the para and post-op of it.
Can I complete? What is the post-operative protocol for this palate?
Once the surgery is completed and shifted to the ICU, then we'll once the child is awake and as much is crying for the feeding, immediately we can start a feeds, and then we can clear fluids. We can give the clear fluids for 24 hours, or if then we can for 2 weeks we have to give on the liquid diet. Then after 2 weeks again we have to examine the child. If there is no complications such as fistula or dehiscence, nothing, then we can go for solid food, whichever the child is taking more at home.
When do you want to discharge the child?
If the child is comfortable, within 48 hours, we can discharge the child.
48 hours.
Awake and comfortable without any complication, no bleeding, we can child discharge within 48 hours.
Okay. When do you call them back?
After 2 weeks. If at all no complications are there and no complaint from the child.
Yeah. Dr. Lakshmi.
Yeah. Thank you, Dr. Parvati and Dr. Anjana. I request the moderators, Dr. Bhattacharya sir and Dr. Arun Kumar Chaudhary sir, to give your inputs and questions, sir.
How do you decide the length and width of the boomerang flap? You have very conveniently said, I'll use boomerang flap. Now, when do you decide and how do you decide? And what will be the length you require and what will be the width?
Sir, length will calculate from the point oval to the nasal posterior nasal spine, sir. That will be the length. And width will be the measurement.
See, as you suture the flaps, posterior to anterior, or you can give a key stitch, or you can hold with forceps. That will give you the idea from how long you need, isn't it? So it is very essential that otherwise either you will be unnecessarily long or you will be short. Then you will lose the advantage of boomerang. Number one. Number two is you said that anterior palate cannot be repaired by VWK. The two flaps rest on the other side. I will advise you not to make a very adamant statement. It can be closed depending upon the availability of tissue and how much you are mobilizing it medially, isn't it?
Yes.
So it can be closed. Those who are practicing, it can be closed. And number three is that the palate repair is purpose is two: feeding and speech. Okay. So what are the segments of speech therapy? Team one.
There are two components in speech, sir. One is the articulatory speech and the resonant speech, sir.
No, I'm not asking that.
We'll
To
start
have
with
a good speech,
yes, sir.
how will you advise the patient party? Do you have a speech therapist?
Yes, sir.
So many of the centers do not have speech therapy, majority in fact, and therefore how will you tell the parents?
We'll start with the speech stimulation, sir. After 6
That's
weeks after the
why I'm
surgery.
asking what are the two segments. I'm telling you there are two segments.
Sir,
What are those?
First thing is we
Yes.
have to tell the child, first he has to hear and learn whichever the parents are telling.
See, for good speech, the palate has to be mobile. And how do you make it mobile? I'm asking you absolutely practical question.
Child to make sounds such as which moves the palate.
What will you say to the parents? What to do once the palate has healed?
We'll ask them speech stimulus by asking them to blow the cheeks by balloon or so that
Yes.
the soft palate is stimulated.
One is balloon inflation. What else? So blowing exercise.
Yes.
Okay, that is segment one. And segment two is speech. So how will you advise speech?
First we
See,
tell the child.
there'll be regional variation from Kashmir to Kanyakumari. Everybody do not use the same language. So you have to decide how to train the parents. Speech therapist is not there. One is to make the mobility blowing exercise. You can use balloon, you can use flute, you can use whistle, and so on. Because the child has to be trained in a form of game. He's a 1 or 2 year old child. And the other thing is speech. Now tell me about the speech. How will you train the parent? Team one?
So one is that mother has to actively communicate with the child.
What are the syllables? What are the syllables you will ask them to emphasize and teach? And the words from it.
we'll ask them for to teach them the syllables which include the letters P, B, T, and D, and the letters S and Sh are the letters which are most difficult for the cleft patients. So we ask the parents to incorporate these letters into the words which they communicate with the child, so that the child might reciprocate.
No.
You are principally correct, because then according to the language, you have to make it and a whole list of it. Whatever comes out from palate, wherever palate plays the role. So blowing exercise and speech, these are the two segments. Otherwise, your palate repair is the outcome is incomplete. Dr. Arun, please.
Sure. Thank you. Well, I've asked the questions and your presentation was good, but the clarity you have to improve and the conception also you have to improve, because the basic principles of palate surgery will depend if you know the pathology well. And you have talked about the BPI or palate-pharyngeal incompetence, then you must know about the hard palate. So what is the major part of the palate, anterior, middle and posterior? Which part is most important as far as the muscles are concerned in the repairing of the incompetence?
Middle part of
How much it is in percentage?
50% will be elevator.
50. Okay, fine. What are the muscles there?
Sir, levator vela palatini.
Anteriorly will be tensor vela palatini, 25%. Middle will be 50%, levator vela palatini, and posteriorly palatoglossus, palatopharyngeus, and musculus uvuli, remaining 25%. Sir.
So then, which is the middle part is more important, okay? So
Yes.
how they are lie? What is the lie of the middle muscles? What is the lie?
Sir, superior most will be the levator muscle, sir, which will be in the transverse.
No,
The musculus uvula will be
sagittally placed. Normally it is horizontal, okay, and transverse.
yes.
But in pathology it is there. So that is the most, and already on speech, Professor Bhattacharya has talked about. But I wanted to know, as a clinician, you must know what are the perpetual evolution and the instrumental evaluation for this speech.
The instrumental evaluation will be done by the nasophageal endoscopy, sir.
Yes, very good.
Then we can also do with an MRI, sir.
MRI, what is needed?
Fluoroscopy is also can be done for the speech
Yes,
assessment.
fluoroscopy, okay.
Yes.
What is that called? Video fluoroscopy for the speech. Okay.
Fluoroscopy, sir.
Yeah. So then anything else? You know anything about nasometry or speech aerodynamics?
Yes, sir. These are done by introducing air from the mouth. Mouthpiece will be attached, which be going into the another machine, which calculates the pressure, how much
So you will be quantitatively and qualitatively assessing the pathologically defect, either with a primary palatal or a secondary palatal surgery. So that then otherwise, if you send every patient for a speech therapy, end of the day, you find the patient has not improved. Then you blame the speech therapist or the patient will blame you, sir, your surgery was not okay. And what about the perpetual evolution of velopharyngeal function?
We can assess intraoperatively by
No. Speech, how Sir has already told what are the, so resonance, nasal emission, and speech sounds. And there is a test called mirror test. Do you know that is mirror test? Dental mirror you put in front of the nose. And if you find there is a fogging, that means the emission is okay. Okay. And there is a straw test also. If you put it in the nose, a straw, and hypernasality you can hear in your ear from the patient. So these are the few tests can be done in that. So anyway, I'm very much thankful to Dr. Parvati and Anjana. I think they have covered almost all the aspects of presentation in the clinical presentation or also in the surgical part of it. And I hope you have done, both of the teams have done well, but there is all for improvement. Thank you.
Thank you, sir. I invite the judges. Any remarks you want to give or questions you would like to put to the teams?
Yeah, thank you, madam. I would just like to ask a few questions. First of all, very good presentations. Just wanted to know the candidates if they are aware about any palatal lift devices or prosthesis.
Either of the two teams who knows, you can answer.
Palatal expanders, Niti expander.
Not expander. I'm talking about the palatal lift prosthesis. Okay, no problem. And after palate repair, when do you prefer the patients if they are in a growing stage or maybe in a stage wherein there is speech? So when do you prefer to send the patients for speech therapy?
After 1 year, ma'am. After the surgery, after 1 year.
Okay, thank you.
Thank you, madam. I invite Dr. Mustafa Kadir. Would you like to ask any questions, sir?
Can you hear me?
Yeah, please.
Yeah. Most of the questions what I wanted to ask, I think it's already been covered, except one question that I would like to uh, ask both the teams that there is a skepticism of growth in terms of palate. So would you worry much about it?
Sir, your voice is not
The question for
clear, sir.
team A, team 1, would you
Sir, voice
worry much
breaking.
about growth restriction or you would worry much about
Sir, your voice is breaking, sir.
Am I audible now?
Yeah.
1 second. I think there's some network issue.
Yes, sir.
Am I audible now?
So still that is
Your
disturbance
voice
is there.
still is breaking little, but still.
No, can you
No, sir, it
see
is
the
not
CD?
clear.
Now I've changed the
Yeah,
location.
it's correct.
Is it
It's very clear.
okay? So the question is, there is a little bit of worry in terms of growth when you do the pallet repair.
Yeah.
So my question to team 1, and then I'll come to team 2. Would you worry much about it, or would your concern be only speech?
We are very much concerned about the growth of the maxilla, sir.
Okay. So if you are so worried, then what would you do in order to counter the negative impact on speech?
So
is there anything that you can do?
Yeah, alternatively, we can, in order to reduce the raw areas and associated with the von Langenbach's technique, we can do the double modified furloughs with the double buccal mucosal flaps along with the double opposing Z-plasties we can do.
And we can also go for maxillary
To reduce the raw areas, we can do.
All right. What about team 2? Would you worry much about the speech? Would you concentrate on the speech, or would you worry about the growth?
So primary intention will be for speech only, sir.
Yeah. Okay. Why do you say that?
Sir, speech it starts immediately before less than 1 year only the speech development starts, sir. Whereas maxillary tuberosity will go on till the child grows. It goes up to 4 to 5 years age. And the speech, once it starts, and if there are any certain deformities develop, even after doing surgery later also, we may not be able to correct the speech abnormalities.
Okay.
Whereas
So
if there is any
your
maxillary
focus.
hyperplasia, we can do distraction, osteotomy something, and we can improve the maxillary thing.
Yeah. Your answer is partly correct, though not fully correct, because if you look at the meta-analysis, there is nothing which is suggestive about a cause and effect of any particular repair in terms of growth restriction. However, as the previous speaker said, if you are doing a furloughs, then that would have less negative impact in terms of speech. And having said that, the primary focus should be on speech, because speech is a very difficult thing to correct. And if there are growth restrictions, there are multiple options, not just osteotomy. You can also do growth modulation. There are various where you can minimize whatever the negative impact in terms of growth. Thank you very much.
Thank you, sir. Now the time for quizzes is over. Both the teams completed their clinical assessment. So, I invite Dr. Altaf Hussain, sir, to proceed with the rest of the spotters. And both teams are open for the questions. Try to answer whoever knows. So, you will be scoring marks in that also.
Shall I screen share, madam?
Yeah, please.
So we'll continue from where we left off. So this is a 9-year-old girl, unoperated cleft. So she comes to you. So well, we presume that you'll operate on this, and I think we'll just summarize it. What are the basic aims of cleft palate repair?
There will be 4 aims of the cleft lip repair, sir. One is, first we have to check the anatomical closure of the palate should be done. Then second will be the speech after the palatal repair is completed. Then it should be that speech should be normally developed. Normal speech should become. Then we should see that there will be no maxillary hypoplasia, and also we should see that there is no eustachial tube blockage after the surgeries.
Brilliant. Very, very nicely put. Very, very good. I think the next question should go to the other team. You have done well. Okay, now this girl you're operated on, can speech improve immediately after a successful operation?
No, sir. Speech, the patient was 9 years old. So speech has already, she has developed the adaptive mechanism of speech. So the improvement will not be immediate. It needs a aggressive speech therapy.
And with that,
to improve the speech.
There will be success.
Excellent. Okay, now you have operated. How will you know that your operation is doing its job? That means your velopharyngeal function is restored. How do you do that? How do you find that out?
At the end of the procedure, we have to see whether the soft palate is touching the posterior pharyngeal wall.
How much is the
Patency
velopharyngeal
of
gap is
you have to see the patent.
and
Will that give you, I mean, it'll make you feel better, but is that proof that your operation is good?
there are some studies which show that the velopharyngeal gap of approximately 6 mm at the end of the surgery is correlating with a good speech outcome in the later age of the child. So,
well, I mean, I'm not talking about that. I need to know whether for sure this child is able to, you have restored the velopharyngeal function for sure. These are conjunctures, yeah? How will you measure 6 millimeters in a rubbery thing inside the mouth? You know, I'm not talking about, the patient is yours. Need not be immediate. When can the earliest, when can you really find out that your operation is successful? You already answered this. You discussed this earlier in your presentations.
We have
by doing the blowing test and movement of the palate, soft palate. Blowing test.
Will that give you the answer?
At 2 weeks.
I mean, how do you visualize the velopharyngeal?
After 2 weeks of the surgery, we can go for video fluoroscopy or nasoendoscopy.
Okay, when will you do that?
After 2 weeks of the surgery, first we start with the speech evaluation, perceptual speech evaluation, and based on that, we'll go for
it's still nasal.
As the child has already developed the compensatory speech, we'll give the speech therapy. After any improvement with the speech therapy, we'll assess the patient. We have to correct the articulatory errors before assessing for the nasality of speech.
So post surgery, immediately after surgery, we have to let the wound heal. Then once the wound heal, after 3 months, we can
When? The question is
3 months.
when?
After 3 months of surgery.
Okay. I mean, I would say 6 months to a year. You need to give the tissues to become 1 year. I mean, 6 months you will get more or less an idea, but ideally you should wait for a year. I mean, these are not hard and fast rules. Don't quote me in exams, but it takes that long. Okay, so you already answered the next question anyway. So you said you will start speech therapy. When will you start speech therapy? The team with Ramya, Krishna,
Yes, sir.
Tulasi.
After 2 weeks of the surgery, we'd like to start with the speech therapy. Sir.
Okay, brilliant. Why 2 weeks?
For the healing of the scars, and after that.
Yeah, I start as soon as the pain comes down. It doesn't matter. 2 weeks is a perfectly good answer, which sometimes I start 2 to 3 days in an older child, or when I redo. Okay, yes. Now this is the child. That's the post palate repair picture, and this is her recording, speech recording.
Audio.
So we are not able to hear it. Sir.
There is no audio, sir.
Audio
is.
Yes.
You cannot hear.
Yes, sir. We can't hear.
Not at all.
No, sir.
The previous one you could hear, isn't it? Is there some way of increasing the? None of you could hear that?
No, we could not hear it.
I'm really sorry.
Even for first case also, audio was not there, sir.
Okay, I could hear. It's very. I've muted some. Just hold on. Just hold on for a minute, madam. No, it's not muted. This is the sound. No? 1 minute. Okay, let's try again. No. We need to put the thing to the right. This is the one. Okay. Now let's try again. Can you hear me now?
No, sir.
There's something. Just move that a bit. Yeah, 1 minute. Sorry. Yeah. Yeah. Now let's try again. Yes. No.
No, sir.
No
You're not
audio,
matching.
sir. No audio.
I'm really sorry. Well, the child was nasal after the operation. After speech therapy, you can see the velopharyngeal closure. So you need to be. I'll just show you the.
Not able to hear.
Yeah, I'm sorry. Yeah, 1 minute. I'm just.
Some glitch in your transmission or somewhere else.
Okay. Now you can see the velopharyngeal closure during speech. Can you hear me now? Can you hear me?
Yes, sir. Yes, sir.
Okay. So you can see that the velopharyngeal sphincter approximates. There are 2 aspects to it. One, when the child swallows, it's going to. That's a different set of muscles. You have to be careful. So during speech, the soft palate moves very, very rapidly. You can see that it's approximating. I know you cannot hear it. There is nothing I can do to sort it out, but you can see that it approximates when the child speaks for certain phonemes. So it can be completely corrected, and the age doesn't seem to matter. It matters. Your operation should be able to restore velopharyngeal function. Once that is restored, speech therapy does the rest. And we have even seen much older patients do well. Okay, that's okay. Now, another case. She is the mother of one of our cleft patients, and she is about 30 plus and 36, I think, and she came to us. You can see she is unoperated. Now I have a set of questions for you. Would you advise palate repair for this lady?
Sir, we will
Yes,
explain
team one. Yeah. Yeah, team two. Yeah, go ahead, please. Yeah, go ahead, sir.
So we'll explain, we'll take the proper history of the mother, sir. Does she has any recurrent EORA, if there's any speech difficulty, anything. And we'll explain her the post-operative.
No, my question is simple. Would you advise palate repair or not?
Yes, sir.
Yes, excellent. I mean, of course, you need to make sure that the patient is fit for surgery. It doesn't matter. Now, the other team, can this wide palate, I mean, very likely this patient did not have a palate repair because somebody might have got a little bit of cold feet. You can see that it's quite a wide cleft. Can this palate be closed at this stage primarily?
No, sir, it cannot be closed primarily.
Really? What makes you, are you just making it up yourself, or you have some authority on it? Are you quoting somebody? Are you?
Yes, sir. We have to see the defect of tissue.
You've seen the defect. It's a big hole.
Yes, sir.
It's in front of you.
Yes, sir. There is a large defect so that we can't do the primary tissue adjustment. There is a more risk of fistula development. There is a more risk of tension in the sutures.
Okay, you are, this is an intelligent guess. You're conjecturing at it, yeah?
Yes.
Okay, you're not quoting anybody. Okay, excellent.
It is
if you're worried about that, would you consider any other surgical procedure to facilitate normal speech?
Yes, sir. We'll proceed with the we use the buccal mucosal flap for the defect tissue along with the along with the double opposing Z-plasties. We'll do so.
Okay, okay. I mean, let me tell you, if it is a non-syndromic and unoperated cleft, there is no cleft that is too wide to close primarily.
Yes.
I mean, there might be one or two very, very rare things, but I have not come across one in, say, 15 to 20,000 cases. Let me tell you what we did. This is what we did. And you can see it was just only done with the Langenbeck release, and that is pre-op, the 2 weeks of surgery, and 1 year down the line. And now this child is okay. Sorry. You can see that this child has got a has a cleft palate, newborn, having difficulty in breathing. You can see what's happening to the chest. Now I have a set of questions for you. This child is very rapidly losing weight. It's almost the birth weight, or a little bit. I mean, it's actually less than the birth weight at several weeks. Why is it so? Team one, please.
The child is in failure to thrive, sir, because of the difficulty in feeding. The child is not able to take the feeds properly and hence is losing weight.
So if you give the child enough feed, the child will be all right. Look at the child again. I mean, I'm sure my audio is lousy, but you can see the video, can't you?
Yes.
So what's happening there?
We can see the chest retraction.
And you can see that, yeah, what's happening with this child? What's wrong with this child?
Mandibular hypoplasia is there, sir, in the child.
Child is not able to breathe properly and is taking more effort from the respiratory muscles.
The case of Peary-Robin sequence, sir, where it is microglossoptosis, hypoglossoptosis, and falling of the muscles. So which case first we have to deal with the respiratory obstruction, and then we have to put a Ryle's tube and give feeding for the child. Then we can take further process. Once the child gains weight, we can go for a proper repairs.
So what I mean, slowly, what I mean, you said you'll put in a nasogastric tube. Is that what you said?
Yes, sir, for feeding, sir.
Okay. Will that help the child breathe better?
We can try
The
positioning.
child is losing weight.
Position can be done
we
in
have
the.
I'll just come back
Can be
just a
lateral
minute,
position,
because both of you didn't answer that question clearly. The child is
Child has
losing
to be-
weight because of what reason? One
Respiratory
is
distress.
not
Respiratory
able to
distress, sir.
feed. Pardon me?
Respiratory distress, sir.
Can you rephrase it? Excessive work of breathing, yeah?
Yes, sir.
Unless
Excessive
you
strain.
relieve that, how much ever supplements or things you give with the Ryle's tube, it's not going to work. And sooner or later, the child is going to have a major problem with the respiratory distress and even die. Yeah.
Yes, sir.
So, what one thing can you do to ease this child?
Sir, nothing in
Prone position,
lateral
we can-
position or prone position, sir.
Prone
Lateral or
position.
prone
Okay.
position.
Okay. This is the child which has been placed prone. Slightly better, but not particularly so.
Yes.
Yeah.
Yes,
Yes,
sir.
sir.
So, what will you do?
Sir, we can put the tongue stitch and we can.
Can they answer first? Can the other team answer, please?
Yes, sir. We can take a tongue stitch and keep it attached to the cheek in the position so that it is not obstructing the airway.
How long will you keep the tongue stitch on? And have you tried doing a tongue stitch?
No.
If you keep pulling at it, your cable is going to cut through sooner or later.
Nasopharyngeal, sir.
Nasopharyngeal airway can work. Yes, that's one way of tiding over the crisis.
Yes, sir.
Tongue lip
What else
adhesion
can you
be
do?
done, sir.
You will do a tongue lip adhesion. Okay, when will you do? Will you do immediately or will you do something else?
We can do immediately, sir.
So tongue lip adhesion is a
Yes.
procedure which involves, it's an operation, or is it
Operation, sir.
something? It's an operation, isn't it? So you need to optimize the child. You position the child, put in an airway, get it ready for surgery, and then you may want to do it. Okay, now this is the child before, and then this is post tongue lip adhesion. So you can see the little button there, isn't it? Here it's the NG tube, orogastric tube that is fixed. Here you can, under the thing, there is a little button. So what you have done is you have temporarily held the tongue using a Prolene suture, but we have also raised a flap at the ventral aspect of the tongue to the buccal aspect of the lower lip, so that by the time this heals, till the time it heals, your button with the Prolene suture holds it. Once it heals, it takes over. So that's the child in the post-op, a few months down the line. So the child is doing well, and when we do the palate repair at about 1 year, we'll release the tongue lip adhesion. Thank you. Madam, can I
Sir.
any questions on this, or I can I stop sharing, or do anybody has any questions on this, madam?
I have a question for you, sir.
Yes,
you
sir.
told about intravellar veloplasty.
Yes,
it is
sir.
not mandatory, but as a rule, even Brian Sutherland showed in NIMS, in a microvascular surgical technique also he has shown for intravellar veloplasty. And we are getting a very good result, even though there are many conventions and school of thought may be different. But by result, we are getting better with a palatoplasty plus intravellar veloplasty. I think the students should carry on what is convention as the exam is concerned. So they should also be aware that yes, intravellar veloplasty has to be done along with a good palatoplasty and pushback.
As far as the students are concerned, I fully agree with you. I think they should carry home the message. But I have done, I mean, this is aside. This is not to be
Yeah, that
discussed
is
in
a
the
difference,
exams.
sir. You are absolutely full of thought.
I,
But yeah.
I was a fellow of Brian Sommerlad, and I learned intravellar veloplasty from him, and I did it for 15 years, sir. And
Maybe, sir. I am going to controversy, but I am talking for the students' interest. So, can you tell anybody what is this instrument? Just for interest and for the students. This is relating to palate, clay palate repair. Anybody? There is a prize for it if anybody gives the answer. Even faculties are also open.
It is used for
Faculties
raising
are
the
also
palate.
open.
It is used for raising the periosteal flap and.
What is its name?
Rose aspirate.
No.
Sir, only one end is seen, sir.
Anybody, I don't tell anybody.
Sir,
It is
show
open
the
to
both ends, sir.
Show
Both
them.
tips. Both tips.
Only one end is seen, sir. The other end is not seen.
Both ends of the instrument.
This is one end and this is another end. This is one end and this is the other end. I expected somebody should tell it.
Double-edged periosteal elevator.
Pardon?
Double-edged periosteal elevator.
No. This is elevator, palatal dissector or elevator, but it is modified. The normal one, if you are using this one, usually in all government setups, we are using this palatal elevators. But this is specially modified by Brian Summerland. This Summerland modified palatal elevator or palatal dissector. This is available by the Chada Surgicals in India. I think it has something to do. There's a right angle here, you can see, to elevate it very nicely, and you can do a good palatal vessels, greater palatine vessels. You can dissect out round the round side and make it almost like what Professor Bhattacharya speaks, dancing flaps of the palatal flaps. Madam, Lakshmi Madam, have you not seen this?
I had seen in the instrument, sir. Yes, sir, I had seen.
Okay, thank you very much. At least somebody has seen it. Okay. Thank you.
Sir, excellent presentation and discussion, Altaf Hussain, sir.
Altaf Hussain sir has been very nice.
Very nicely
I'm
framed
only wishing you that more extra priority.
Yes. Perry Robbins.
Yeah.
Now I invite Dr. Parvati to show the parap and post-op of the case, what she shared to PGs. And any other cases she wants to discuss.
I think I'll show the only one case.
Yeah.
This is the same child which was given to the students. This child came to us at the age of 9 months. In our institute, we are routinely practicing single stage correction, repairing the lip and palate together. We start with the palate repair and then go for the lip repair and closed nasal dissection with interdermal stitch and web stitch. So this is the central picture is immediate post-op on that day 1. This is about that I think about 10 years after the surgery, and all the wounds healed well, and his arch alignment was completed, and he was ready for alveolar bone grafting. And you can see the arch alignment, little bit is in. Then we had gone for speech evaluation. I think this is recorded probably at the age of 13 years. The resting velopharyngeal, we follow the velopharyngeal competency using video fluoroscopy. It is not exactly the video fluoroscopy, it is digital fluoroscopy. We use the DSA lab for the evaluation. This is the resting velopharyngeal gap when the child is at rest, and this is the closure, what we can see, complete closure at the velopharynx. This is his speech.
Yours. Okay.
పాపకి పాలు ఇవ్వు, పాపకు పాలివ్వు, పాపకు పాలివ్వు. ఈ బాబు పేరు బాబీ, ఈ బాబు పేరు బాబీ, ఈ బాబు పేరు బాబీ. తాతపై తేలు, తాతపై తేలు, తాతపై తేలు. డబ్బాలో దూది లేదు, డబ్బాలో దూది లేదు, డబ్బాలో దూది లేదు. టీవీలో పాటలు చూడు, టీవీలో పాటలు చూడు, టీవీలో పాటలు చూడు. వాడి డోలు కొత్తది, వాడి డోలు కొత్తది.
Parvati?
వాడి డోలు కొత్తది.
Actually, that moment and all are not visible.
సాయి శశి ఊరికి వెళ్ళారు.
Actually, your screen is not fully visible.
Oh. How come? I can see it fully.
Is it same for all or?
We are able to see in the left side the verbal phonitions, and the right side you can see the video fluoroscopy.
Could you hear, sir?
Yeah, we can hear.
This is the fluoroscopy.
Yeah, I'm able to see here. Very much we can see the video also.
Yes.
It is fine now. It is fine now.
Yeah. Very nicely displayed.
Yeah.
So now he is about 13 years of age. At 10 years of age, when we did the ABG, the arch was all right. Now I can make out little bit of hypoplasia on the cleft side. Probably will follow, and further skeletal surgeries we might have to do in future. That is about the first case.
Good.
I think that I'll stop here, and
very nice.
I just wanted
follow
to
up, Parvati.
Thank you.
Very good approximation, and palatal function is visible in this video. Very
I just
nice.
wanted to show that we can do single stage palate and the nose pleasant here, and the growth is good, and there are no fistulas. When we started doing single stage correction, we never had any anterior palatal fistulas. Occasionally we might have had mid palatal fistulas in very wide clefts, but rest of the clefts, group 3 clefts, I think single stage correction is fine.
If you don't think of fistula, fistula will never come. Don't think of fistula, then no fistula will be.
Okay. Yeah. That's it from my side, sir. Thank you.
Thank you. Very nice display and very good surgical repair.
Thank you, sir.
Now I will invite Dr. Anjana to show her cases and share her experience. Dr. Anjana is Manvai child. Dr. Anjana, are you available? Is she there? Dr. Anjana, can we share your PPT? Are you available?
Anjana ma'am?
Dr.
Madam,
Anjana,
Madam Achen?
I don't think she is available because she is in airport and joined the meeting. I think she may not be available. Next time we can ask her to present her cases.
Dr. Lakshmi, can I utilize this time?
Yes, sir. Yes, sir. That's what I am going to invite you. Yes, sir.
I
Please.
think three aspects have not been covered.
Yes, sir.
My question to both the teams, you repair a pallet and then after 3 hours, you get a phone call that there is bleeding on phone. Now, what do you do?
So first thing is we'll advise the sister to turn the child in the lateral position.
Very good.
And we'll try to
do
put
not
a
put
gauze pack in
do
the
not
raw
put
areas.
any suction. Do not put any suction into the mouth, and as we'll advise put a gauze piece and repeat a pressure till we go. Once we'll go, we'll see what the.
What else? The other team?
That's it, sir.
Lateral position. What else?
Lateral position, we'll put a gauze pack in the raw areas on the lateral sides so that it will give
No,
the
you
complete
can't see
motion.
raw area. Child is weeping, crying. You
Child
can't
can
handle.
be sedated, sir, so that he'll be comfortable and
It will be still more difficult situation. You raise the foot end of the bed.
Concealer position. You should have
Okay,
a concealer position.
so that the blood doesn't trickle down. Number one. So this is on phone. And then you rush. Then you rush. So then what do you do? With this position, you ask the sisters to transfer the patient to the OT. And you go to OT. Then what do you do? I mean, this may happen anytime in best hands. So it is not complete without this.
Adrenaline gauze. I'll put the adrenaline gauze in the raw areas, sir.
You are not seeing anything. Child is 2 years old, crying, restless.
We'll try to sedate the child and we'll see where the bleeding source is.
No, dear, don't sedate it.
We'll put
You have to re-intubate and see the bleeder. And while re-intubating, what precaution will you take?
The tube should not touch the pharyngeal wall, hard palate, suture line.
No. You have to tell the anesthetist the palate is already repaired. Be very careful with your laryngoscope so that the repaired palate is not damaged. And then very carefully and good anesthetist will intubate. And then what do? You see the bleeder. And cauterize it or suture it, whatever you want. Okay, this can happen. And therefore, two lessons. One is you should be available. Don't go for party at night on that day. And second thing is your instrument should be ready. Don't take out from the Sidex or whatever it is. You ask the sisters, OT staff to keep your instrument ready that night. Don't waste time. You don't have time to waste. This is number one. And the other thing is, again, coming back to fistula. None of you could could answer the repair. The principle of fistula anywhere in the body is that it is repaired in 2 layers and the 2 suture lines should not fall in the same plane. Therefore, for palate, for example, if somebody does palate repair or hypospadias repair, he must know how to repair the fistula because nobody can get 100% result. It may not be surgical fault. There may be other reasons. So you hinge a flap from one side. You assess the tissue availability. You hinge a flap for lining on one side, defect based. That means you have to keep at least 1.5 millimeter base so that it supplies that hinge flap, the turnover flap. And then from the other side, you transpose a flap. So this is a classical example of a major surgery for a smaller defect. So you need a turnover flap and a transposition flap. So you have to assess that. And then if it is say 2 centimeters or beyond, or there's a lot of fibrosis and not much tissue available, then what do? What's your answer for closure of palate? Fistula? The answer is whatever tissue is available from all around, you turn it over as a lining. and then give a tongue flap. And that is usually a anteriorly based tongue flap, because that has more malleability and the patient do not have much problem post-operative. So fistula, I thought it should be dealt. And the third point is, in which cases and on what basis you decide pharyngoplasty. The parents have given speech therapy. They're tired of giving speech therapy and they're telling, sir, we have done sincerely and still the voice is not good. And then you say, okay, we'll do something more. And that is pharyngoplasty. So in which case, how do you decide pharyngoplasty?
Sir, basing on the closure of the velopharyngeal port, sir, we'll see whether it is the closure is circular closure or sagittal closure or coronal closure. Based on that, we'll plan for the surgery, sir.
So what surgery you plan?
If it's due to the defect of the soft palate, we'll go for Furlow's double slit plasty, sir. If it's due to the improper movement of the lateral walls, we can go for superior
interpharyngoplasty,
pedicle
or if
plasty.
the closure is because problem is if in the posterior pharyngeal wall, then we go for the pharyngeal flaps, posterior pharyngeal wall.
So when you do a superiorly based pharyngeal flap, how do you decide the thickness of the flap? That this is the plane in which I should raise.
So this should be, when we raise the flap, it should be prevertebral, sir. Only the prevertebral fascia should be visible.
Prevertebral fascia. How do you identify the prevertebral fascia? How does it look?
It's shiny white layer.
Yes, it's a glistening structure. And that's the plane which is almost bloodless and you have already infiltrated. And then once you have raised it, what do you do to the donor side?
Primary closure can be done, sir.
Yes. And does it have any beneficial effect?
Raw area will be reduced, sir, and bleeding will also
Anything
be
else?
Bleeding
Anything
will
else?
be
Anything else?
We can use the, if needed, we can.
It reduces the velopharyngeal port space, sir.
See, the megalopharynx, the room is reduced. Okay. So you get two advantages. The room is reduced and you increase the length of the pharynx and the soft palate. And how do you suture that superiorly based pharyngeal flap to the posterior border of soft palate?
We'll create the raw area of the posterior border of the.
How do you create that raw area? What is the incision?
We'll raise the posteriorly placed flap of the nasal layer over the soft palates.
What is the direction of the incision? How does the incision look like?
U-shape incisions.
No. So you have to line most of the pharyngeal flap, as well as you have to insert the pharyngeal flap to the posterior border of soft palate wherever you want to suture it. So you have to line it. If you don't line it, what will happen? As much as possible, you have to line it. In long run, it will become like a string, like a rubber band. It curls on itself. So you may get the advantage of directional advantage of pharyngeal flap, that means superiorly towards the perseverance ridge, but you may not get the advantage of the width of it because it will just fold and become a string. So you must line it, and therefore your incision for inserting the pharyngeal flap into the posterior soft palate is very essential. You make straight incision and then go horizontally so that you can unfold the mucosal layer of the flap. That will line the pharyngeal flap. Okay, so this is very essential, very practical things which I thought I should highlight on this.
Can I speak 1 minute, if you allow me? Well, during the surgery, what is more important? How do you assess how much of bleeding have been there? Any of the teams?
Based on the gauze pieces counts.
Gauze piece, how do you assess it? How much of blood, suppose in a 1-year child, how much percentage of blood loss can be taken as?
There are up to 100 ml. Since we assume the baby weight is 10
what
kg.
percentage? How many percent of blood loss?
10%, less than 10% should be there.
15%, not less than 15%. That cannot be changed. You can ask any anesthesiologist. Okay. So blood grouping and cross matching has to be done by a resident. If you're young, if you are doing very early, in pallet case, for all practical purpose, you should have a blood ready for the patient. Okay. So infant, you should, what is the unit for an infant? How much is the quantity of blood?
Sir, 30 ml per kg body weight, sir.
No. I'm asking what is the packet for an infant? What is the packet for an adult?
Per kg, sir. 100
Huh?
150 ml packet will be available, sir.
For an infant, you give 150? You check it in your place. I don't know. In our place, is it different? In your place, you check it. That is very important. Second is, rightly somebody has told in from group 1, I think, that after the bleeding is there and there is a transient time when the anesthesiologist is easily not available in government system. And that period, how do you utilize to stop the bleeding?
Adrenaline boost,
pressure packing.
adrenaline soaked gauze piece.
Ice cold soaked cotton and put adrenaline into that, and you can put the air tube, small one, the pediatric one in the OT, which was used by the anesthesiologist, and you put the patient into a tonsillar position, and you put your finger with the cotton in it, with adrenaline, with that soaked from the ice, and press it. Usually, sometime from the anterior palatine vessel, there is a bleeding. Once the blood pressure goes up. Most of time, when you are seeing an operation, you have to see the blood pressure also of the patients, either in palate or in case of microvascular surgeries. So as a surgeon, it is also your duty to monitor the blood pressure. It should not be too high, it should not be too low. And after the operation is over, they will increase it. And you have all the problems then. So in palate is very important for the young people that primary these things should be done to stop the bleeding. In a tonsillar position, keep the patient and put a cotton soaked with ice and also with adrenaline and try to press it with a ART one, so that you will not, otherwise patient may, if the your elder patient is there, he can also put the tooth onto your fingers. So that is the, I think in the Durga Puja, last Durga Puja, I had a case like this. My resident was good enough at least to do this. Then when I go and see the bleeding, almost it has stopped. So sometimes it happens, not always. As Sarah has told, in those cases, the bleeding do not stop, and the bleeding, and you should have a blood in with you, cross-matched and group and cross-matched with you. When you become experienced surgeon, then you can anticipate and you can have your planning in that way that you may not require blood. But for all young resident, I tell you, you should have a blood with you, because immediately you may not get the blood, may not be possible also. Thank you very much for this small comment.
Thank you very much, sir.
Hmm.
Dr. B. Venkatratnam has joined. Would you like to say anything, Dr. Venkatratnam, sir?
Without his voice, we will not be happy.
Yeah. We missed in the last session.
Yeah, that's why I'm telling you, no?
Dr. Altaf sir has joined for the first time. Sir, how did you feel? How you